Hi, welcome to another episode of I Own a Business, where we focus on helping practice owners grow the practice of their dreams. I'm your host, Dr. Steve Vargo, and I have with me today Dr. Amanda Nanasy, who practices in South Florida, where she specializes in vision assessment and training, as well as neuro-optometric rehab following concussion. She's a team physician for several professional and NCAA teams and brings a broad range of expertise in areas of visual performance, injury prevention, and recovery. Thank you for joining, Dr. Amanda.
Thanks for having me, Steve. It's always great to be here with you.
We're going to talk about something today that I think we hear regularly from patients, but we're going to challenge the status quo on something. We're going to try to answer a few questions about this topic, starting with, are we doing everything we can to help these patients who are experiencing this symptom? Do we understand this condition as well as we should? And if the answers to those questions are no, are we missing out on practice building potential? So the symptom I'm referring to,
Drum roll.
I'm going to add that in later if I can figure out how to do it. So here's my little drum roll. Headaches, good old fashioned headaches. So before we jump in on that topic, for context, could you tell us a little bit about your practice? There's a bit of uniqueness to your practice. So tell us a little bit about that and how do headaches in general fit into your practice model?
I'm co-owner of a six-doctor practice, which we like to say that we're multi-specialty now because even though we do primary care, we have docs that do myopia control and specialty contact lenses, and we do vision therapy, and we do dry eye, and we like to think of ourselves as far as optometry goes, a one-stop shop that can fit all of our patients' needs by just inter-referring to each other. So, from a practice standpoint, we love what we've built here. And from my specialty, seeing concussion patients, we've done, I think, a really successful job of taking something that patients didn't know we could help with. And by educating not only patients, but local providers, other centers that are treating concussion patients, I've gotten a really great referral network going on here to help those specific patients. But that same thing that I've done could easily be replicated for a symptom that we all hear about every single day, and that's headaches. And that's kind of, I think, how we came upon this.
You treat a lot of concussion patients, you treat athletes, you mentioned referrals. I want to unpack some of those things as we go along, but I'm curious from your standpoint as well. The working title of this episode is "Could Your Patient's Headache Journey End with You?" And I think a lot of times a headache journey starts with us. I think there's a
Mhm.
lot of patients who are getting headaches and they go to their eye doctor to see if there's something going on with their vision, but it doesn't necessarily end with us. And that's what I want to ask you about. In fairness, headaches are complex, and
Yes.
optometrists, we're not always holding the cure. There's a lot of different things that could cause headaches, but the question is, are we doing all we can? Can you speak
Right.
to things that we could be doing within our scope that we're not doing?
Yes. And I think a lot of that starts with even just the basics of we're taught in school to Dr. Flops, all the headaches, make sure that they don't have a brain tumor, make sure that it's not something that I need to refer them out to. And then a lot of times we're just kind of taking note of it and then moving on and hoping that a change in their prescription, the same thing that you've been doing every year, is enough. But there are some other things that we can sometimes do to help them, and there are things that are more out of the scope of what the patient might feel comfortable with, where I dive into specialty tints and things like that. And then there are things that are completely in the realm of the patient was already expecting that they might need glasses when they see me, but what if I can give them just a different type of glasses that at best make their headaches go away, which would be amazing. And at a minimum, might just make them feel even more comfortable than they did in their previous glasses. And even at a bare minimum, they know that now I'm not just refracting them and doing 1-2, which is better, and just giving them the same old glasses that they think that we've always been able to do, but we're elevating the level of care. And it's crazy how many patients may not bring up headaches or even visual fatigue until I do some tests and say, hey, this is kind of a little bit different than what I would expect. Do you ever have trouble with kids, tracking? Do you lose your place? Do they have a hard time focusing and doing their homework? And they're like, yes. And then again, it's one of those things that elevates care when I can potentially address those issues for them.
So on the topic of issues, there is a something that I like to call the problem behind the problem, right? I think as doctors, we get pretty good at seeing the symptoms. We get pretty good at seeing the condition, but we don't always see the problem underneath the problem in terms of how is that issue affecting their daily life. And I'll give you an example from your world of treating headaches and working with athletes. Professional athletes paid millions of dollars who suffer with migraines. And in some cases, they can't play. I mean, anyone who's experienced migraines, it's debilitating. So they can't play. They're paying millions of dollars and they're not able to go out there and play. So it's not just
Yeah.
the headache, but how is that headache affecting us in our lives? So is that something that you're able to dig into and surface some of these issues? What related conditions, in addition to just the pain of a headache, can you treat?
Right. Well, before I answer your question, I have to do a little side note and said that how does it affect you is something that I learned in one of your lectures, and I've added to my questionnaires when I'm speaking to headache patients. And if providers get one or two things out of this time listening to this today, I think that can make such a big difference. If they say, "Oh, I get headaches that are 6 out of 10 when I'm on the computer after an hour," and you just say, how does that affect you? That's the difference between like, oh, it just affects me a little bit. I'm kind of okay. Let me rub some dirt on it versus, it is impacting me dramatically. So I'm definitely interested in anything that you can give me that might help. I think it's such a great question to ask. Um, Things that can cause headaches. When we're doing our tests, eye misalignment is always something that I am looking for. My core of what I've always done here has always revolved around binocular vision and how the eyes need to work together as a team. And we really started seeing headaches flare when everyone got sent home during COVID and spent all day here, because any small misalignments that they had that I was seeing on a cover test, right? I can be a little extra fancy and do my infraopter gray forias and things like that, which I typically do. I like those. But just a cover test, if I say they've got a pretty significant misalignment, meaning a foria, and phorias are normal, completely normal. We expect to see aphoria. You're probably not all testing compensating ranges and vergence ranges and how much essentially that patient can lift during a day before they get stressed and strained. But that misalignment, if pushed to the level, can definitely trigger those headaches. And then sometimes I'm known to go down the rabbit hole with patients and explain sometimes too much, but I will tell them that the cranial nerve 5 that tells your eyes where to point is coincidentally and unfortunately for us the only nerve that innervates the whole head. So even when you have been diagnosed with a migraine by a neurologist, and again, not all headaches are caused by eye issues, right? There are other things happening. But if you have a migraine and you have that vascular system that's contracting, the only sensory nerve that is surrounding all of those blood vessels is cranial nerve 5. And that's the one that we're overstimulating. So if we can take some of that strain off of that system, potentially lessen even the frequency of you getting those headaches because we're not flaring an already impacted system, then we've got a chance to take a potential huge swipe at the headaches that the patients are that they're experiencing. I feel like I should stop there and see what questions you might have, because I will just keep going the whole time, Steve. You know me.
Well, and that's why I love having you on. It's, you're passionate about this topic, which I think drives a lot of, your expertise and success in this area. And I appreciate the shout out. It's something that um, I've come to really appreciate the difference as a doctor, the difference between treating and connecting with people.
Mm.
And all doctors treat, but not all of them are equally effective at connecting with people. And I think the more we understand really what somebody's going through, how that condition is affecting them, the better we can connect with them. And the data supports that we'll have more success, outcomes improve, non-compliance drops when a patient feels a sense of connection with their doctor. When that patient can look at their doctor and think to themselves, you get me, you know what I'm
Yeah.
going through, they're much more likely to follow through with whatever your treatment plans are. When we spoke before, you mentioned treating concussion patients, and you said something, I had written it down, referring to other practices. They may not have concussion patients, but they have
Mhm.
headache patients. If they say they don't, they're not asking the right questions. So
Yeah.
I was reading something recently about three areas, how people reveal information. It tends to fall into three areas. And there's the unknown, unspoken, which I don't know I have an issue, right? So it's unlikely I'm going to mention it because I don't even know there's an issue. It's unknown, it's unspoken, right? Where you may not get that information or we need to get better at surfacing it. Another area was known and spoken, right? Dr. Nanasy, I got headaches, they're bad. Can you help me? Right? It's known, it's spoken. But the area I think headaches a lot of times fall into is this third category, known, unspoken. And I think a lot of symptoms not necessarily associated, at least in the patient's mind, with vision, fall into that category. So how do you create awareness of this in your practice? And how do you make sure that you're getting that information from people who may not be apt to just to reveal it?
Well, I have to say I rely heavily on my staff helping me with this. And from a patient perspective, there is probably only a few things as frustrating as doing an intake form and then talking to a medical assistant and again telling them what's wrong and then having the doctor walk in and say, so what brings you in here today? And I'm like, why did I waste all of my time? And we have some really great questionnaires that we have for all of the various things we do here, right? Like I have a lifestyle index specifically for contoured prism. I have a speed questionnaire for dry eye, all of these different ones. So we took bits and pieces from what we thought were the most important ones and we put them in our intake, that our patients are all answering these questions before they see us, and our technicians then go through all of those questions before they bring them back. And based on what they see, they will decide. And again, this is putting a lot of responsibility on the technicians there. If they're going to say, oh, wow, they hit this one, and this one, I need to run this test on them. Or they said these things, we should run this test on them. And that's where we're sometimes starting up the questioning with the headaches when we do specific questions. Do you get headaches during the day? Do you feel discomfort when you're on the computer? Motion sensitivity is a question that comes up, which people will be like, oh, yeah, I've always got motion sickness in a car, but no one's ever asked me about that before. I didn't think I was supposed to tell you that. And it turns out that's also heavily linked to a high exophoria. Um, so I don't know if that answers your question, Steve, but that's kind of how we start the conversation. And sometimes it will go in the other direction where they didn't say that they had headaches, but then I do testing and then I ask the question and then it jumps to the other category you said where, yeah, they get headaches, but they didn't think that I could help them. So they just didn't bring it up. So that's the reason why I think that we need to educate patients at every single point we can, because you never know what you're going to say that's then going to spark a symptom that they weren't reporting. We try to get it out of them before they even see us so we can run the appropriate tests.
Yeah, I think so much comes from asking more questions, whether that's in a questionnaire, a lifestyle questionnaire, or something you give them before, something that the tech asked, or even you. And the question you mentioned before that I had pointed out in the lecture, how is this affecting you, is really just part of a broader um, list of questions that I had provided that get information out of people. So I think if we spend more time asking questions, we'll get more information, and the solution starts to become easier. I think sometimes doctors do this. I coach some sales teams, and one of the main things that I notice is that I've tried to coach on is they get a little bit of information and then they jump in with the solution without
Mhm.
fully understanding the problem. I think doctors are guilty of that as well. So asking more
Absolutely.
questions. The next question I want to ask you, it at the risk of this may be a silly question, but watch that not stop me from asking it. Is there a target market for headaches, or is it just anybody with a headache? I know you focus on athletes, student athletes. I mean, are we targeting the techie, the kids on their devices? Is it the 20 to 30-year-olds in techie jobs, or is it just should we be marketing this to anybody with a headache?
I think that when you start just with anyone with a headache. And then once you get confident enough and you get some great results under your belt, that's where your marketing hat really needs to come on. And you need to say, wow, this is a great demographic. To your point, the anybody IT, anybody that's sitting on a computer all day, which it's not really, it's like everybody now, so many people are. Students are not carrying books anymore. My daughter started sixth grade this year and she's on an iPad literally all day. She even does math tests on her iPad. So it's even worse than we suspected in some cases, but it's near point to me. Anyone that has a high amount of near point is someone that I could have a really high chance of helping with a contoured prism. It doesn't mean that that's the only people that are getting headaches. People are waking up with headaches and having these horrible life-changing symptoms. And again, even if I can give them something that can reduce a trigger, it's going to help them. But did I even answer your question? I don't know. Everyone, like there's kids, there are working adults, there are retirees that you have new presbyopes, you have people that have always been fine up close, and then all of a sudden I try to put an ad power on them and their posture comes out like this now. So now they're not compensating as well as they were before. Some of them don't adapt to progressives well because of a misalignment. And I'll have people that are new to my patient, they're new to my practice that have tried progressive years ago and they never did well in them. And I'll say, I think I might know why. And boy, do I feel like a genius wizard when I can solve this problem that once you do it a couple times and you'll look for it and it doesn't take extra time, but you can help those patients as well.
So, in a minute, I want to dig into some of the technology that you use. But before that, I think an important area that I'd like to get your insights on comes from the referral and co-managing aspect. And real or perceived, I think sometimes our relationships with MDs is not always symbiotic. And maybe this is some of our own insecurities that we need to overcome. But I'm curious about your experience with co-managing patients and communicating with those providers, because I know that's a big part of your patient base in terms of TBI, in terms of concussion, in terms of headache. Maybe any advice? How do you handle that? And maybe any advice to other people that are looking for those referral sources for other MDs who like to refer to MDs in some cases.
Yeah. It's all about just educating the other party. And I think that as ODs, sometimes we're kind of hesitant to think that we want to tell an MD or a DO something that they don't already know because it makes us seem like, oh, we're so smart, or you don't want them to feel that way. But I've had some of the best conversations. Even I had one with an ophthalmologist, a pediatrician, a pediatric ophthalmologist that I refer back and forth to. The first time that they saw one of my patients that had Prism, and he called me and he was like, "I'm not really a big fan of prescribing Prism typically," and I was like, let me tell you what I'm doing and why. And of course, he had never heard of what I was doing, and he was interested in all of the studies, and it was fantastic. And then it it was never a question again. He knew exactly what I was doing and why. And the conversations with the physical therapist and the concussion specialists, the neuropsychologists, they are even better because they are in our world and we don't think that they are. But I just had another patient this morning that actually was seeing a physical therapist for vestibular therapy, and he pulled a Brock string out of his bag, and my extern looked at me and I was like, I told you. And like I had him explain how he was using it, and of course it wasn't correct. So we got the information for where he was going, and I was like, all right, Matt, we're going to make a house call and we're going to go visit them and tell them that we really really appreciate how much they are thinking that vision is a part of the puzzle, because a lot of people don't realize that. So it's fantastic. But let's share some of our thoughts and how we can work together. And it's just opening up that line of communication. I give everybody my cell phone number, and say, just call me if you have any questions. And the next time they have a patient that they think might be a good fit, they're going to call me, and all it takes is one good result. And
Mhm.
then the referral floodgate will open.
Yeah, I love that last part because I had actually written down outcomes right here. Because once you start doing this and you get outcomes, you get results, you can lean on that, which is always, I think, going to be more impactful than claims, right?
Mhm.
We all have some almost healthy skepticism to a lot of things we hear. Let's just put ourselves in the position of an MD who's maybe not overly familiar with our work as ODs and what we do and what we can and can't treat. And when they're hearing about something in terms of claims, they may still have some level of skepticism. But like you said, once you start getting results, even just one result, I think at the end of the day, every healthcare professional wants what's best for their patients, right? They want to put them in the hands of somebody who can help them resolve their issue if it's not them. So once you start doing this and you start getting results, I think that's um, an incredible opportunity there to continue to get more referrals. We touched before on the technology that's made our lives really easy, but not necessarily good for the eyes. The
Mhm.
iPads, the phones, it's the world we live in now. But if we could transition into some of the technology that's that's actually helping, that's solving some of these problems. So uh, you're an advocate for Neurolens as an option. And for those, a lot of people are probably familiar with Neurolens, but for those who aren't, could you explain what Neurolens is and how it differentiates from traditional lenses?
I can. And it's funny because I was almost holding my tongue because I do COPE lectures on helping patients with headaches. And I'm like, I can't say Neurolens. And I was like, okay, he said it. I think I can say it. We're not COPE. So, right. So, Neurolens is something that I've been using in my practice for years now. And when it first came out, I probably made a jerk of myself because I like approached them and I was like, I want to use contoured prism. It makes total sense, but I don't need all your crap. I don't need to buy your equipment. I just want to prescribe the lenses. And they were like, well, you have to buy the equipment. Long story short, now I love it, and I'll tell you why. But the whole contoured prism, starting there, because that's the root of what got me there. Most people are going to tend to be more closer to orthophoric in the distance and then have some sort of an exophoric issue at near. There are obviously going to be, variations of that, but that's a large majority of the patients. So I would have these super sick people coming into my office that, were dizzy and couldn't function because I've had head injuries. And I wanted to give them one pair of glasses instead of two pair of glasses or three pairs of glasses. So the fact that I can give them more prism where they need it up close was exactly what I wanted and what I needed for the patient. And then once I started kind of connecting the dots and saying, well, these patients are having headaches because their system that was once able to basically accommodate for this misalignment, and now it can't do it so well. or compensate maybe is a better word, so I don't confuse focusing. They can't compensate anymore. Now they're symptomatic. I could take patients that have always been symptomatic because they weren't compensating well and give them a similar treatment. And that's kind of where that bridge happened for me, where I said, well, let me start using this for my patients that haven't had head injuries, but are still having these headaches and getting those same outcomes. The reason why I advocate for Neurolens is it's very clear, and there's one big point behind it. I am okay taking an hour for an exam with a concussion patient, but my primary care doctors are seeing patients every 15 minutes or 20 minutes, and they don't have time to necessarily do all of the extra testing that I do. A lot of doctors feel uncomfortable prescribing Prism because it's too complicated. They're opening up a can of worms, whatever the reasons they are. So what Neurolens has done is they've developed this headset that you put on the patient. It looks cool. It's great technology. So even if the patient's not a good candidate for Neurolens, they're going to be impressed with what they were tested on in your office that day, and it spits out the number and it tells you if they are symptomatic, here's the amount of Prism to give them. So it puts in the hands of every single practitioner that has it the ability to help these patients where they maybe would not have had the confidence to do it before. And I think that that elevates our profession. It makes us more than just a basic refraction, and that's why I love it.
You hit on a few things there that align with something I hear from a lot of doctors. And if you're a vendor, if you're an entrepreneur, or somebody who's developing technology for the field, I'll give you three things that I hear all the time from doctors when it comes to technology. And I think Neurolens is something that checks the three boxes. One is they'll rave about how it makes things easier for them.
Mhm.
If it's easy to use, it makes it easier for the staff. It's easy for the patients. You mentioned, and it is. Prism is kind of complicated, and I think if a lot of ODs are being honest, they don't understand it that well. How do I measure for it? How much do I prescribe? It's sort of been this sort of fuzzy area that it's been hard for ODs to quantify. And through the technology and through what Neurolens is developed, it's just made it a lot easier. It's taken some of that complex. Man, I'm gonna have to edit that part, Amanda. Complexity? I'm leaving that in.
Back it up.
Complexity. Yeah, that took too long. Number two, it sells itself. People say like, I love technology that sells itself. And another one was technology that doesn't disrupt the flow. And I think that's the same thing with specialty care. Anything that gets us out of that quote unquote traditional care. One of the biggest obstacles I hear from doctors is we just don't have time to do it. So
Mhm.
something that is quick, to your reference to your other doctors who want to keep things moving along. So I think it does a great job checking those boxes. I want to ask you about patients who are skeptical, and maybe this is not just focused on someone coming in and hearing about Neurolens. I don't want to isolate that. There's always going to be some healthy level of skepticism when people are hearing about something for the first time,
Yeah.
but just headaches in general. I mean, patients who've been to other doctors and been seen by other professionals and they're still getting the headaches. And now you're saying you have the answer, you have the cure. How do you overcome some of that skepticism? And feel free to mention I think a nice little option with Neurolens. If it doesn't work, they get their money back, right?
Yeah, they take it back. I mean, there is to me nothing of a bigger hammer to break down that wall than saying you have absolutely nothing to lose. And I will sometimes even say that to the patient, that if you get these glasses and you do not feel a change in your symptoms. And by the way, I recorded your symptoms because I wanted to make sure that they were impacting you and that we would be able to quantify that they are making a difference for you when you get these glasses. If you get them and they're not making a difference for you, I want you to come back and see me because one, and again, like I'm sure that they're gonna Neurolens will love that I just broadcast this out there. Like they'll do a remake for me because if I need to make a small change in the prescription, sometimes that happens. They'll do that for us. And then if you still are not feeling that they made any difference, you'll get your money back. And honestly, it's a bigger hassle for us doing the return and processing everything, but I'm willing to take that risk because I'm that confident that this will make a difference for you. And going back to the sales, more sales end of things, and you were talking about, the patient communication in the chair right there. That's the point where I say, does this sound like it's something that you want to go forward with? Are your headaches impacting your life enough that you want to try this? Are we doing this? I don't say, well, this is one of the options, and then send them out to optical for optical to drop price tags on them and things like that. I tell them these glasses will be potentially more expensive than what you would have paid for the glasses that you got from us last year. You have a great vision plan, but you won't be able to use the vision plan benefit for the lenses themselves. And if you end up not getting the glasses, your glasses, or if you end up not doing the Neurolens, your glasses will still be fantastic. You'll see clearly, see clearly. But the difference here is I'm going to try to address the comfort, not just the clarity. That's what makes this different. That's why it's not covered by the vision plan. But again, if you and I make this decision that it's worth it, we're in it together. And I mean, as an optometrist, I say this all the time. It's hard because we wear the hat of a doctor and then we also sell stuff. And sometimes the doctors don't want to prescribe the things that are going to cost more money. But who am I to value the impact that I can have if I take out their headaches? They pay tons of money for medications that make them feel sick sometimes. They get Botox injections for migraines. They go to chiropractors. They go to acupuncturists. Headache patients are some of the most overburdened of them all. So if there's even a chance I can help them, I typically, I think, have a pretty good capture rate on at least letting them let me give it a try for them.
I'm going to make a lot of ODs cringe. I love remakes because if the product is good, if the technology is good, most people aren't going to take you up on it. And you've just got to look at the sales. If that lowers the barrier, if that's what it takes.
Yeah.
Let me rephrase this. I don't love remakes. The 100% guarantee I'm a big fan of, because I think companies that do this know that only X small percentage of those people are going to take them up on it, but sales are going to go up
Yeah.
pretty significantly. And through that, I think you just build in that X number of remakes are going to happen, and that's just built in as a cost. If the product isn't good, then it's not worth it. This is dependent on the product and the technology being good. But if it is, I think you can comfortably have that as a policy. And I like the way you approach the patients. Once you've elicited the problem, again, goes back to what we were talking about before, understanding how it's affecting them, what are their biggest pain points, not just the headache itself, but how is it affecting them. At the end, circling back to, is this something that you want to move forward with? And I read somewhere that I know we're not, traditional salespeople, but I think still pulling things from the world of sales makes for a good analogy. Um, Somebody said the best way to sell something is make people feel stupid for saying no. And if you've done your job throughout the course of the education and asking questions, you almost make people at the end, for especially with a money back guarantee,
Yeah.
we'll take them back. You almost make people feel stupid for saying no. Um,
Yeah.
just a,
What's the catch, right?
right, yeah. What's the catch? And if there isn't one, but I think another area that we can lean on when we are trying to overcome skepticism, and we talked about this before, is that can we prove it actually works? That's how it's proof always trumps claims. So I'm just curious, either with Neurolens specific or just in general, any specific stories that you have of a patient that you helped, and now you can kind of lean on that story now to help people, to maybe influence people's decisions or help them overcome their own skepticism.
Yeah, gosh, I mean I have so many, and I have so many different types of stories. I can tell you that there were kids that I helped that came in with concussions, and I ended up putting them in Neurolenses and getting their symptoms to be gone. And then the parents were like, "Oh, I want to see you for a visit." And then there was this one mom that I saw, and I ended up prescribing them for her as well. No concussion, just misalignment, occasional headaches, eye strain, never liked to read. And she came back and saw me and said, I read a whole book since I saw you. She said, I used to love to read, but I haven't been able to. She was 40 something, right? So ever since she needed the plus, she just didn't want to read anymore because she couldn't adapt. And she said, I've been calling this the summer I learned to read again. And she referred so many of her mom friends to me. So she really stands out. Another story that I like to talk about is one where I saw a sister that had a concussion, and actually, she wasn't a concussion. She was somebody that had she had like intermittent double vision and long standing headaches, and had been to like a neurologist and a primary and her ophthalmologist and everything. Everyone said nothing's wrong, you're fine. And I gave her Neurolenses and fixed her problems. But the cool part was the next part where I saw one of her sisters a couple months later, and she was in the chair, and I had no idea that she was related to the other girl that I had helped. And I got to the point in the conversation where I was like, this girl could use Neurolenses. And it's not always because they have a big foria. Sometimes they have a small foria, but they're super symptomatic. This girl was like 10 exo, and I was like, this is pretty big. I'm pretty sure I can help you. And I started to say, these lenses aren't covered. And the mom stopped me and said, Dr. Nanasy, I'm pretty sure, are you going to prescribe Neurolenses? And I was like, yes. And she said, you hadn't met me before because my daughter's sister came with her grandma last time, but you prescribed Neurolenses for her and they helped her. And that's why we're here, because we're hoping that you can also help this daughter. So I was like, it's funny. I'm such a nerd. Like I get goosebumps every time I talk about the story because it meant so much to me, because the mom was essentially saying, I trust you. You don't have to give me the rest of the pitch. Like I know what you're going to do is going to be helpful. And that's how it's been for a lot of patients. I get the ones that are super problematic, but then the more patients you help, the more you see, the more confidence as a provider I have for prescribing the product, right? Because it's not just horrible reasons to prescribe it, but maybe even if they're a little bit symptomatic, again, if I can get rid of that. I always like to use this quote from Dr. Borish when I lecture about this, because we're taught in school that prism is for diplopia. But the quote something like, a small amount of prism can make a big change in comfort. And he didn't even say anything about double vision. He acknowledged that it can help with comfort, and that's what we're doing.
I think it's such an impactful way to communicate value to other people is through stories. As doctors, sometimes we get caught up in a lot of the clinical terminology and jargon, which a lot of times just goes over the patient's head and they nod their head up and down, or they'll forget a lot of what they left there with. But I was getting goosebumps when you were talking about those patients, and I don't even know who they are. But no, so it's such an impactful way, and they will remember. So the more you're treating this, the more you start to collect those stories. Um, and the more you share that with other people, it's relatable. And I think that, patients are going to lean into that. I wish doctors would use this more often as a tool to bring people in and get them to consider treatment options, is just share stories of success that you've had with other patients, especially ones that can relate. If I got a patient who says, these headaches, I used to love to read and now I can't. Well, you've got a story in your back pocket that it is at least going to get them to lean in and seriously consider this as an option. So, I'll close out here. I mean, we're doctors first, but if you own your own practice, we're business people as well. So obviously we didn't talk a lot about this, but there would seem to be a tremendous practice building potential of
Yeah.
having can we call it a headache clinic inside of a OD practice?
Absolutely. And I want to make sure we connect the dots there, right? So I had those great patient stories. Several of of those patients were seeing other providers, right? So if you really want to build your clinic, that's the point, when you have them back and you get those stories, and I'm not afraid. Like, you ask my staff, like, if I'm prescribing a Neurolens for someone, and again, people will be like, what kind of can of worms are you opening? I will say, I want to see you 2 to 3 weeks after pickup, because I want to gather good stories.
Mhm.
And if they have someone that they've been seeing for their headaches, that's where you send the letter out. You say, you know what, I'm so glad you're doing great. Would it be okay if I send a letter over to your primary care doctor or your neurologist or whoever it is you've been seeing for these headaches, and let them know that you're doing well? And that opens up the door, for that conversation to happen, to where then you might get more referrals being sent your way. You can certainly just do it from the practice itself, internal marketing, sharing testimonials. But when you start sharing with other providers, guess what? Like, headache doctors don't want to have unhappy patients that they can't fix.
Mhm.
So my neuropsychologists, they don't want to have concussion patients that keep failing all of the visual tests on their impact. So if they can add me as a part of their weapons, to use to help their patients, now I'm helping their practice. I'm not competing with their practice. And I think maybe that's sometimes what we feel like: send them to me, I can fix them. But no, guess what? I'm a partner now with you, and I help you with your patients.
I hadn't considered the impact of the patient going back and acting sort of as a middleman or middlewoman with the doctor, because they're going to go back and tell that doctor. Now we're more than just some, anonymous doctor standing at the front desk with a stack of business cards and some cookies, hoping that the doctor will talk to us. But you've actually treated that patient. They're going back to that doctor and saying, "Hey, this really works. I really had a great experience with Dr. Nanasy, and now that doctor's, hopefully skepticism starts to drop and they're much more
Yeah.
apt to want to work with you, being able to demonstrate that." So, Amanda, thank you so much as always. I really appreciate you talking about this.
Thank you so much, Steve. And hopefully we've inspired some people to help some more headache patients at their own practice.
I have no doubt. And you will be at the iDoc Connection speaking. So, what are you
I
speaking
will.
about?
So if all goes well, I believe I might be doing a lecture about headache patients specifically. And if that happens, I'll be sure to always bring some different useful forms and things like that that can maybe help the docs with their referrals and really get the ball rolling so they leave with actionable items.
Great. Well, thanks again. I'm gonna let you get back to work. We caught you on your lunch. You're gracious enough to forego a lunch, at least your lunch hour. So, really appreciate you coming on.
Thanks, Steve. See you soon.
So, thanks everyone for listening. And if you enjoyed today's episode, please subscribe to our podcast wherever you're listening, leave a review, and share it with your friends and colleagues. You can follow us on Facebook, Instagram, and LinkedIn. And to learn more about iDoc, you can visit our website at idoc.net. That's idoc.net. And check out the links in our show notes for some helpful resources for your practice. So, see you next time and keep dreaming big.